irrational things continuing to exist just bother me. And our healthcare system is wildly irrational. The incentives have to change. Fee-for-service and family medicine just don't mix. When you turn family medicine into visits and I get paid for visits, well, that's not what primary care is. Primary care is like taking care of a population. So I think of direct primary care as just non-fee-for-service primary care. The membership in direct primary care gets you your physician, their time. So whether you text them, email them, call them, they stitch you up on a weekend, like there's no extra cost for the physician's time. But then what direct primary care should be doing is...
I'm Judson Howe. I lead hospitals. I've seen a lot of what's broken in healthcare, but we're going to find out ways to make this better. This is Healthcare Reframed. I met Dr. Brandon Alleman 2 years ago when I was introduced by another guest, Benjamin Anderson. And the context of the introduction was this guy really understands a different model of healthcare called direct primary care. I had never heard of it before. Apparently, it's a model where instead of us pushing healthcare onto patients, sometimes 1, 2, and 3,000 patients in a panel, instead, these people have opted out of that system. And these doctors have banded together to take patients in a very different model where they're paid directly by these patients, not per visit, but for having a relationship, almost like you have an attorney on retainer, or like when some of you have a physician in the family where you can just call them up whenever you need them. It's a lot like that. Some people criticize this model, saying it's inequitable. Not everyone has access to it. Dr. Brandon Alleman has put a lot of work into making sure that this model is available to everybody. It's a bit of a flashpoint in healthcare. Some people see this as the extreme fringes of healthcare. Others see this as the burgeoning future of healthcare. Enjoy the conversation with Dr. Brandon Alleman. So you're an MD, PhD, Fulbright scholar, and you chose to go to family medicine, a specialty that in the medical hierarchy is often seen as lower on the ladder. Yeah. What led you to make that decision?
Yeah, I think looking at it in retrospect, it was a couple things. We were part of a community at Iowa, part of a house church in Iowa, and the community aspect of how can family medicine impact the community was interesting to me. The other one that I joke with my wife is that I always say I'm functionally unemployable, like I could never work for anyone. And so I was aware of direct primary care even in medical school. And I was like, yeah, if I ever am probably going to practice medicine, that's the only place that would ever employ me is me starting a clinic. So I had some inklings of that, even choosing a specialty. So,
I want to know more about functionally unemployable. What does that mean?
Sometimes people ask me, like, am I a rule follower? And like, it depends. We don't break rules just for the sake of breaking rules, right? Like we don't try to get put in jail just by like not doing our taxes or things. Like we follow normal rules. But the we're just going to do this because we've always done it that way. I have never like tried to follow those rules. And so, going into an institution is just hard to integrate in that system. So I kind of knew that I was gonna probably do something on my own post training. So family medicine, again, if you're a surgeon or you're an orthopedist or you're a urologist, it's very hard to like spin up your own urology clinic. But family medicine offered this kind of different pathway, an easier ramp to start something new.
Give me an example of a rule that you felt you needed to challenge.
Yeah, I mean, a little bit leading into the incentives and stuff we'll talk about later. Like family medicine, fee-for-service and family medicine just don't mix, right? Fee-for-service and primary care. Like if I do a procedure, like if I do a colonoscopy, I don't do colonoscopy. Somebody does a colonoscopy, takes 20 minutes. It's very like, we started it, we stopped, and I'm paid an amount of money for this. That makes total sense. When you turn family medicine into visits and I get paid for visits, well, that's not what primary care is. Primary care is like taking care of a population. So that was just a rule that I could never understand, like why we should do it that way. Why my reimbursement should be tied to like these chunked out things, if that makes sense.
Yeah. So let's look at different incentives around this. Yeah. But let's go back then to you're choosing to go into family medicine for, it sounds like almost like a moral or maybe values perspective.
It's probably giving me more credit than at the time.
So then recraft that then.
Yeah, I think family medicine afforded me the opportunity to like explore what I wanted to explore.
Okay.
So doing primary care differently, and probably the more impactful classes I took in medical school were not like pathology. I mean, we have to know those things, but they offered actually evening courses at Iowa where you could do global health and you could do U.S. healthcare systems. So those are the things that kind of impacted me to like seeing the issues with systems and saying like, well, how are we going to address these? So even in medical school, the business school had a pitch competition. And so I won an amount of money to like start a business in a pitch competition, trying to bring price transparency to like simple procedures. The business failed miserably, but because I didn't have time to do it while writing a thesis. But that should always on my mind about like, what can you do to change this direction? So.
Yeah. Tell us, you mentioned pitch competition.
Mm-hmm.
Why did you enter a pitch competition?
So with that medical tourism paper that I wrote, the option was like, there's no price transparency in the US, so I have to fly to India to get my knee surgery done.
Yeah.
So the thought was like, well, why can't there be price transparency in the US? So the pitch was, hey, we want to, for common procedures, colonoscopies, simple surgery, simple orthopedic procedures. The idea at that time was the lending tree model. So I post that I need a colonoscopy and people bid on my colonoscopy, right?
Whoa.
So that was the goal. Again, failed miserably. I didn't get off the ground. But that was the thought.
You think it failed though because you didn't put the time into it?
Well, that was certainly an option.
Do you think the idea would work if someone put the time into it?
I mean, I think you're seeing models for bundled prices and price transparency come up. I think it was probably the wrong time for it. Again, this was right around the time of the ACA, so not as much. There wasn't as much movement in this direction of price transparency as there is now. So I think it was early to be successful in that. So.
Yeah. So Brandon, why did you choose to go to Wichita then for your family medicine residency?
Yeah, it's interesting because part of the reason for doing MD PhD is I didn't know how much clinical medicine I would like. And then as I was in medical school and doing things, it's like, oh, I really like the OB floor and I'm really interested in ER and I like metabolic disease and I can't really decide. I love the operating room at that time. But oftentimes people that are interested in several things wind up in family medicine because you get to do a little bit of all of that. And the reason I came to Wichita for family medicine, one, somebody I started med school with, Nick Thompson, who we wound up starting our clinic with.
Okay.
He had gone to this residency program, and this residency, the Via Christi Family Medicine program was known for doing lots of those things. So they had good obstetric training, they had good inpatient training. Lots of the residents moonlit in ERs and rural ERs to increase their skills. So it was just a place that didn't limit my scope of practice at all.
In my time in the healthcare ecosystem, I've heard people critique family medicine for trying to be jacks of all trade. Mm-hmm. How would you react to someone that has someone ever said that to you?
Yeah. Can we pause for a second?
Yeah, absolutely.
Can you pull up that full quote? The jack of all trades quote. Do you know the second part of it?
It's going to be great.
Will you pull it up? I forget what it says. Yes, people shouldn't be dangerous. In the past, have some family medicine physicians maybe been dangerous in the things they're attempting, possibly. But I would say what our system lacks is medical homes for people, and because family medicine, you may need to take care of babies, you may need to take care of metabolic disease, you may need to diagnose cancer, you may need to perform simple procedures. You need to be trained broadly. That's going to depend on your context. If I'm rural, I may be the only one in the county delivering babies. Well, that's not the case in Wichita, but there's just still a way for me to work with specialists on all of those different areas. So, don't be dangerous. Yeah, what's the full quote? So it says, jack of all trades, master of none, but 10 times better than master of one.
It's funny how I've never heard the full.
Yes. So everybody critiques the jack of all trades.
Say it again though.
But so I think, am I getting it right? I'll try to say it again. So it's jack of all trades, master of none, but 10 times better than master of one. So that is the, when people accuse family medicine of being jack of all trades, I'm not trying to say that family medicine is better than a specialist, but it's still needed and it's still valuable to have that perspective.
So you talked about
There's
safety is important, and no one goes out to practice medicine that would harm people. How does a family medicine physician draw the line between the desire to practice a broader spectrum and safety for the patient's care?
Yeah, again, that's your abilities and your context. So am I as good of an ER doctor as somebody who's board certified in emergency medicine? Not a chance. But even as a second and third year resident, when I would go out to rural communities, if their ERs are currently staffed by people who are sometimes much less trained than I was even as a second year resident. So it fully depends on your context. Like family medicine doing low risk OB, I think makes perfect sense in a lot of settings, right? Keeps care within the family. You keep your practice growing. You have good relationships with the people you're working with, but there are ways for family medicine. Now, am I going to do like gallbladder surgery and appendectomies that some people in rural Utah, like, no, that's not my context.
Well, we say like it's crazy, but I mean, I know family physicians doing, like you said, colonoscopies and, C-sections.
Yep.
And there's really kind of a loose definition of broad spectrum and full spectrum.
Yeah.
In fact, I've heard someone say full spectrum is probably one of the most overused, non-meaningful terms in family medicine.
Yeah, I think family medicine as a specialty is turning into two things. There's some people who go into it because it's easier than internal medicine or pediatrics to go through, and they're planning to be outpatient only.
Yeah.
That's not the vision of family medicine that exists here in Kansas. So I think especially people coming to programs like Via Christi's program, they should at least start out expecting to do more than just clinic only. So.
Yeah. What makes Via Christi a program that better trains family medicine?
Yeah, I think it's that relationship. So they are, they're in a hospital that does obstetrics and doesn't have an OB-GYN residency there. They have their own medicine services, so it's not just joining an internal medicine service.
Yeah.
And then they have dedicated faculty and we're in clinic and doing those things. So you're kind of hitting all the major aspects. And then in a community that's willing to train you in more things. So willing to train you in colonoscopies, willing to train you in other procedures. So they're just, whatever you want to make of that training is available to you in Wichita. And Wichita's kind of the home of family medicine.
So you mentioned there's two types of family practice physicians. Maybe there's those that didn't get into other specialties, but then sounds like there's like a set of elite physicians that chose family medicine as a specialty for the reasons you just mentioned, maybe a broader spectrum or continuity of care or relationships with patients, the ability to explore different parts of medicine. How would someone in healthcare go about screening for that type of doctor, assuming that's the type of doctor that they want in their...
I don't know if you could know that. I mean, you could know where they trained. You could see what they do. You could see how they interact, but I don't know if there's a way to, without sitting down and meeting them a few times to know that before you meet them.
Yeah.
And if it's a 3-month wait to get into them, that's a hard thing to try multiple doctors. So.
Right. So after Via Christi, you decided to continue to not be an employee of someone else, but to be an entrepreneurial in medicine.
Yeah.
What did that lead you to?
So yeah, I was aware of direct primary care. And I use that term because that's the most common term. We can get into what is
direct primary care?
I think of direct primary care as just non-fee-for-service primary care. And I think of it as a medical home. So instead of me being tied to 99213s and 99214s, which are codes to get paid for an office visit, I am paid on a recurring basis, usually a monthly basis in direct primary care, to be somebody's medical home.
Like Netflix.
To create a medical home. I think the better analogy I often use is Costco, because Costco has a membership, right?
Yeah.
You pay a membership to Costco. The membership in direct primary care gets you your physician, their time. So whether you text them, email them, call them, they stitch you up on a weekend, like there's no extra cost for the physician's time. But then what direct primary care should be doing is making all the other things in medicine cost effective and accessible. So a blood count in our office costs $3.50, I think, right? And maybe even less than that, maybe like $2.75.
Okay.
But because you're a member, I don't need to make money off the lab order. So lisinopril costs $5 for 100 pill supply. I don't need to make money off dispensing that medicine to you. So it's flipping the model of primary care. It's like, well, we can only get paid for these visits, so we got to see this many patients a day. To if I'm taking care of 600 to 800 people, my job is to take care of them really well. The revenue is already there once they're members of our clinic. So decided to go into that model versus like going into a traditional fee-for-service model.
Would you make money off of those procedures and those pharmaceuticals?
Oh, yeah. I mean...
Until you're choosing not to.
Yeah, that is... I mean, the goal with ancillary is to cover your costs. There may be some margin that needs to be there to keep it going. But what we don't want to happen is our physicians to make money off prescribing those things.
Why wouldn't you want that?
Incentives. I mean, we're going to get to, I'm probably going to say that word 75 times through the rest of this.
Let's get there. Yeah.
Freakonomics. Everybody's read or heard of Freakonomics.
Maybe not everybody.
But Stephen Levitt, the author, was asked like, well, like summarize the book. And he's like, well, if I had to summarize the book, it's just like incentives.
It's matter. Incentives.
Yeah. So I want physicians, I want my incentive and physicians that work in our model's incentive is to like deliver great care to patients. If the patients are members and they are receiving great care and choose to remain members, the physicians are going to do well. If I charged $15 for a CBC, I would still undercut the entire market, right? It's cheaper than any lab test now. It's cheaper than walking into LabCorp. But if I paid my physicians and said, hey, we can make money off CBCs, but we would order a lot more unnecessary CBCs. So keeping the incentive, hey, we're going to make money off the membership, and then we make our membership valuable by offering other services. That's the way we do. Everything doesn't fall into that. So I do obstetrics. So we have a charge for my time to deliver a baby in the hospital. Dr. Nick, who I started the clinic with, he does vasectomies, and so he makes money off doing the vasectomy. But those are skills that are outside of like primary care, if that makes sense.
If this is such a good model, why aren't we seeing this be more pervasive across family medicine?
Yeah.
Maybe should I say family medicine or primary care?
I would say primary care.
Okay.
Yeah, I would say primary care. It's growing. So when we started our clinic in 2016, I think we were one of like 200-ish. So we weren't the first by any means, but we were kind of that next wave of like, this is probably the right way to do primary care. Fast forward 9 years, and we're at the 2,000 to 3,000 clinics. So a tenfold increase over 10 years. So it's not decreasing in popularity. It is not the mainstream by any means. I think it's not the mainstream because of the incentives of how healthcare is bought and purchased right now. So that's probably our next area that we're going into.
You have a subscription model. Yeah. You're the Costco of healthcare.
And that's how we started out. So 2016, we actually started as I started my third year residency. So Dr. Nick he took patients for a year. I did all the accounting and back end and like get off the ground startup stuff. And then joined clinically when I got out of residency. And so we started out with that subscription model, and then just grew in patients because we were delivering great care. I mean, Nick grew very quickly his first year because he delivered great care.
What did that look like to you from an opportunity cost perspective? In California, first year resident grads are making $270 to $320 a year.
Yeah.
Is that about what you were seeing?
For ourselves?
Yeah.
Oh, no. I didn't pay myself a salary for 2 years from the business, right?
For 2 years?
For 2 years, yeah. One was residency. I was in residency. That was year one. Year two, worked an entire clinical year and took no money out of the business to be able to grow it. So supported my family by like moonlighting and additional things like on weekends. So no, the opportunity cost. Yes, you can go be employed and certainly make a bigger paycheck initially. The sacrifices that you would have to make to get that paycheck were not worth it to me. So it never, getting the paycheck would have felt like a sacrifice to me. The like getting to do the medicine I wanted was the main driver of that.
How did you put food on your table? You probably did. I mean, I don't know your situation, but yeah. A lot of physicians have student debt, responsibilities.
Yes. So that would be the one way that, the one unique thing I think about both Nick and I's situation and starting Antioch is the MD, PhD afforded me the opportunity to have no debt. So your tuition is completely paid for, and you're actually paid a stipend during those 7 years. So I came out of medical school with no debt. Nick had the year in between kind of deciding what to do, so did a lot of moonlighting, was able to pay off debt. So we entered starting a practice mostly debt-free. I understand that's not the situation of a lot of physicians.
Yeah, because I'm
Although in family medicine, you have a valuable degree and there's always moonlighting opportunities. So people could be in less debt if they decided to do that. So,
to moonlight.
Yeah, to work while you're in residency. I mean, family medicine's great, is not the most demanding of residencies. So there's some opportunities to make money in residency if you would like to as family medicine.
What I want to...
That's probably controversial me saying that, but
it is controversial.
I think it's true.
So family medicine may be an easier residency than some of the procedural specialties.
Neurosurgery, yeah. And then like general surgery, yeah. So
okay. All 3 years. Is it 3 years for family medicine?
Family medicine 3 years, surgery's 5 years, OB-GYN's 4 years. Again, these specialties are working more hours and for longer years in residency. So that's where it's just a little bit harder to start your own thing out of a residency like that.
Yeah. So I'm intrigued by this DPC idea, and we have yourself finding a model, although it's requiring sacrifice financially to be in the model.
I'm big on not making sacrifices, so I wouldn't characterize it like that. Like,
so how
it's a temporal sacrifice in that, like, I didn't get a paycheck, but doing the right thing is never a sacrifice. So,
is that ethos instilled in your peers across the profession?
I'm allowed to keep making controversial statements. Is that okay?
I hope so. Yeah.
I think instead of being instilled, it's actively beaten out of people from when they walk into medical school to when they leave residency. Medicine is a lot about conformity, and the hey, think differently is nowhere cultivated in medical training. So I think you get a lot of idealistic people entering medical school. 50% of that idealism is gone at the end of medical school.
In medical school.
And then some people still come into like family medicine residency and be like, I have these big goals. I'm going to do Irrational. I'm going to do whatever. And then 3 years of more training, you lose even more people.
Why do you think this system is set up that way to reduce?
I don't think it's intentionally set up that way. Okay. I think that is just the byproduct of the incentive. So like, hey, we got to hit these clinic numbers. You got to do this many rotations. You're still accruing debt while you're in residency. A lot, you're not paying down any of your debt. I didn't mean to demean family medicine too much. I mean, you're working more hours than you would work as an attending in residency. And so you leave and be like, okay, whatever job is going to pay me something that I don't hate is what I'm going to take, I think is a lot of times to happen. But like the thinking outside the box, and I'm going to take a risk and I'm going to do those things. Medicine does not select for people who are willing to take risks. So, and that's a good thing.
So maybe
that's a good thing clinically a lot of time, but it's a bad thing entrepreneurially to change a system.
How would we go about getting more entrepreneurship into medicine?
I don't know. Yeah. I think, again, you change the system, right? That's the only thing I could think, right? If I view the system as like, well, insurance companies pay me and I get paid to do 99213s and 99214s, and I have to do the math of just how many people do I see a day. There's no way to innovate. I mean, there's very little way to innovate in that system because the math only works one way. And you get to the point where there's, in primary care, oftentimes primary care is a loss leader. So the only people, the options facing you as primary care are, I am employed. So I go to work at a hospital system. The hospital system is going to tell me, hey, we lose money on you, but we keep you around to like refer into the more lucrative things. That's the reason hospital systems oftentimes keep primary care around as a catch net into more lucrative things. There's large independent primary care that most of the time they make their money off ancillary services. So I own an MRI, I own a CT, I own the lab. Well, I make 70% of my revenue running people through those things and not really doing primary care. That's the other model that can be financially viable. Neither of those things align a physician's value with the patient's values. So I forget what question
What
I'm
can
answering.
physicians? Yeah. Well, what can physicians do collectively? Like, if you could get some critical mass of physicians, maybe 1,000 physicians in a given geography, to go with you on this journey to think about incentives differently, what could you get done?
I don't know that you need that many physicians to be entrepreneurial. I just think that's not the right distribution. You may if we are allowed to go into Austrian economics.
I hope so. Yeah.
So Mises in his book Human Actions talks about leaders, and sometimes he's like, well, not everybody's a leader, right? But leaders like teach people to go down this path. But he's like, what often is missed is they're like trailblazers who, like, the path doesn't exist. They make the path. The leaders then lead people down that path, if that makes sense. So I think you, for the vast majority of people to make a change, they have to see a new path as viable. I think we're just at that point in medicine that some people are blazing a trail. The leaders are just starting to see that trail, and now we're starting to see some migration in that direction. So
my mind goes to this image of like someone in this dangerous trailblazing setting. Almost they could die, right? And then the other leaders would be like, "Oh, see, that didn't work."
Yeah. So it's funny, if in the book Mises describes the trailblazers as the most miserable people. They're never happy. They're beat up. They like.
Does that describe you?
My wife would say sometimes. I'm trying to be a little bit more healthy than that, but I am prone to dissatisfaction, I would say.
Yeah.
So, yeah.
What drives you?
I think I've answered that question in the past of like, just like irrational things continuing to exist just bother me. Like, they can't stay irrational for that long. And our healthcare system is wildly irrational. Well, irrational in the sense of that you wouldn't design it this way, but it makes sense if you follow the incentives have to change.
Why do you think the rest of us tolerate the irrationality?
I don't think people understand it. It's one of the big things. So I give this talk, the state of the U.S. healthcare system, and I give it to whoever will listen. But I've given it to the OB-GYN residency here. I've given it to the family med residency here. I'm giving it to the ACP meeting later this fall. But it's like
what's ACP?
It's internal medicine, so American College of Physicians. It's just a local chapter. But people see that the system isn't working like they want it to work, but they don't understand why it's working the way it is. So step one is just like understanding why the system works the way it is. If I understand that, well, now I can start to say like, well, what can I capable of change? But I think it's just physicians specifically have this moral injury, right? I know this should be happening for my patients. It's not happening, but I don't feel like there's a path to happen to it. So another example I always use, my favorite back surgeon in town doesn't do back surgery anymore because he owns a gym, because that's the best way to help people with back pain, right? I don't want to speak for him, but it could happen that somebody who's trying to do the right thing gets the message of, well, you really just need to be in the OR more, even though if that's not the right thing. Well, people leave medicine when they have that level of moral injury.
Did you watch that YouTube video last year from the username was Gooby and Doobie? And it was a neurosurgeon from MIT who sounds like what you just described. He was describing the moral injury that was occurring to him as the profession, the specialty shifted from trauma and ER based to elective. And the pressures were pushing him towards more and more elective cases. Yeah. And at one point in time, he realized internally that he was performing highly technical surgeries on patients that then would just come back to him 6 or 7 months later. So high risk, they would improve for a period of time, but they wouldn't change their lifestyle. And conversely, he also noticed that some patients he'd schedule for surgery, they would qualify, and they would change their lifestyle, and then they wouldn't need his surgery.
Yeah, right.
And so he started asking himself this question of like, what am I doing?
Yeah.
So he walked away.
Yep. Yeah. And I think you see that, surgery is the obvious example, but like if I'm doing primary care and I get the message from can I say hospital CEO? Am I allowed to say that?
Absolutely. Yeah.
I get the message from my CEO that says like, well, you're seeing 22 people. You really need to see 30. There's no way I can feel like I can do a good job. So my options are like stay up charting later, like see my kids less, or like, hey, just cut some corners. And like, well, You have diabetes, like go see an endocrinologist. So, hey, you got some pain, just like go see a sports medicine. Like, people adapt in a way to get by, but they don't like it. They know that's not what they should be doing. And so they can only do it for so long. So
yeah, I mean, I don't like thinking about anyone in medicine cutting a corner.
Right. But I mean, what are the options? If I'm given a task that I can't do in 8 hours, I either have to do it in 12 or I do less.
Yeah, well, I think that's one of the things I'm trying to figure out from you, because you've actually transcended up and you've said, well, what are those options? And you've said, well, I'm going to play a different game. I'm putting words in your mouth.
Yeah,
here.
no, I use those exact words. Play a different game.
I'm going to play a different game. You guys keep playing that game. It's not perfect. What would you say to somebody? And I have heard this comment. And I'll share a little anecdote with you. I was exploring DPCs. I met you a couple years ago, and then it got me curious about DPCs. And I spoke to another DPC provider in the New England area, and he had maybe more the stereotypical look, the ponytail, the Birkenstocks, and he was selling it. Like he was selling it to the T. But I took someone with me who happened to be a CMO, internal medicine gerontologist. And I took him with me to the meeting, and that person that went with me walked out of the meeting about halfway through to take a phone call that I could tell wasn't really an important phone call. And on the way home, I asked this CMO gerontologist, why did you walk away from that conversation? He says, I left so frustrated. And I was like, well, what were you frustrated about? He's like, I left frustrated because here is a physician that's really gifted at what they do. And instead of being a part of the solution, they decided to take their toys and go home. I think is what he said. He might have said Monopoly board and flip it over. I don't know which he said, but I'm guessing you've heard similar comments like that. Yeah. How would you react to that?
And that's why I use DPC, because it's the most recognizable thing. So let me kind of paint the landscape of what I think. So in the 80s, 90s, there was concierge medicine. And so DPC is always accused of being concierge medicine. The history of concierge medicine is what I call double dipping. So I charge you the retainer so that I can have fancy cupboards in my office and I can have a fountain and all this stuff, but I also bill your insurance. So DPC is not concierge medicine from that aspect. I'm not double dipping. I'm not charging the retainer and billing insurance. I know people that pay upwards of $1,000 a month to go to a hospital-based primary care just because their office is super nice. That's concierge medicine, right?
You said hospital-based.
Yeah, I mean, it's a major hospital system that is basically catering to CEOs. So you don't have to wait in line. You'll get into specialists faster. You pay us this huge retainer. We're still going to bill your BUCA-based insurance, but you get to feel special because you have, the fancy office to come to. That's concierge medicine. I will say DPC runs the gamut. So DPC, what characterizes that? I'm not doing third-party billing. I don't have any contracts with traditional payers. But there are spectrum within that. So the physician you're describing with the ponytail, I would say he's chosen to be a non-combatant, right?
Okay.
He's burned out. He's like, hey, I found 500 people that like me. They're going to pay me some money to do good medicine, but I'm done. You know what I mean? It's hard for me to fault those people because what are their options? Stay in the system and continue to receive moral injury. So I don't fault people. I kind of those are the micro practice DPCs, right? I may take on a nurse practitioner. I may have one other doctor, but hey, it's the two of us. We found our 1,000 patients. We're good, right? Great. They're going to deliver good care to those patients. Fine. I think the criticism of you're not affecting the system is true, but it's not their moral right to go be. It's not their moral responsibility to continue to be abused by the system, right? So, do I wish they would have a little bit for it to take? Yes, but I don't think they're to blame. The other end of the spectrum is, as people have realized, fee-for-service primary care is not really a workable model. You're trying to see corporate DPC. So you've seen private equity invest in DPC. You've seen large.
Give me an example. It was One Medical example.
So One Medical bought a direct primary care in Colorado, and then One Medical was purchased by Amazon. So I mean, that's a pretty large investment.
And there's others you're saying as well.
Yeah.
Okay.
There's other investments like that taking place. So that's a little bit of a corporatization of DPC. I don't know what the future of that will be, but that's one hey, how do we hyperscale this? I think what we are trying to fall into is that medical care is local. And medical care is not as much a commodity as Like if I buy, buy folders off Amazon, it's harder to commoditize a medical home in that way. Maybe it can be done, but most, 97% of the medical care that's going to be received by people who live in Wichita is going to occur in Wichita. You may very rarely have somebody need to go to Denver or need to go to Oklahoma City or need to go to Kansas City, but healthcare is local. I think the right scaling and the right way to change the system is building a local healthcare system that does it differently and has the right incentives. So that's the model that our direct primary care is moving towards. That's the model that we're trying to affect in our area.
So I want to link back to, we've kind of hit around the moral injury. We've used the term a couple times, and you used the example a moment ago of it's not someone's responsibility to subject themselves to a system that's abusing them.
Right.
Draw a tighter line between that thread and how DPC is a solution or an antidote for that experience.
Yeah. I mean, I think it's for those people that are kind of opting out, it's the antidote of I'm just gone from the system. To me, direct primary care has been a thin end of the wedge to like start making some change in the way more healthcare is done. So
this is that trailblazing.
Yeah. So I think when you go into primary care, you're like, man, I want to take care of people so they're healthy. But medicines help do that. But then there are lots of other things that help do that isn't classified as isn't classified as like medicine. If I wrote a prescription for them to go buy like vegetables, right, that would hugely impact their health, but can't be done in our current system. I don't have a perfect answer to that now. Yeah. But if I'm not tied to a very narrow payment model, I can do what things are valuable for my patients. So
you mean an example of how you've done something different in a DPC model? Sorry to cut you off.
Great. No, you're leading. Perfect question. So the example of that, around the time of COVID, mental health became a huge issue. So we actually came across a master's level social worker that was just starting out. And she's like, well, I'll just have my office at your practice for your patients. I will take a cash-based rate that's half of the rate because you're referring directly to me. It's a warm handoff, and I don't have to spend all the money on like having an office and doing other things. I can make a living by charging less, by partnering with a direct primary care like that. So we brought mental health into our clinic. We're currently in talks. I was talking to somebody that we met here beforehand about how big of a spend musculoskeletal medicine is. Well, how do we've had kind of direct contracts with physical therapy to refer directly into that to avoid them having surgery. So again, when you are taking care of a population and you aren't tied to visits for your income, I can think, what does my population need to be healthy? Let's spend the dollars there.
Your DPC is called Antioch Med.
Yep.
In Antioch Med, I've seen other, even hospital systems, start looking at the determinants of health and maybe the social factors around the patients as well. And I have actually, I'll speak for myself. When I was an administrator, we invested heavily in running programs, mobility training programs. In fact, a system that I worked for actually purchased an internationally known lifestyle program to build communities of health.
Mm-hmm.
I don't know if they worked, but I do want to get a sense for DPCs. How does your DPC look at some of those factors?
Well, why am I allowed to ask questions?
Go.
What happened to those programs?
We were targeting a Medicaid population, kind of influenced heavily by the Camden Coalition projects. We did not do a good job of quantifying the efficacy of those programs. Those programs still do exist, but they're very challenging. This is to your point, I think. It's very challenging to tie those back to monetary efficacy. Now, I will say for you, our incentives were different. For the Medicaid population, we were under a capitation program.
Mm.
And so my incentives, the reason I'm even sitting here in this chair is because for 10 years, I was for 80,000 members of my community, which was a community of 190,000 people. So it's a large number. I was paid under a model of reducing inpatient utilization.
Mm-hmm.
And so I imperfectly and really naively am curious about how do we reduce inpatient utilization.
Yeah.
And in that journey, I know that I know very little. And I know that the traditional medical continuum is really wholly unprepared to reduce utilization.
Yeah. And that's what I come back to when I hear about programs like that. Oftentimes it comes down to, well, the payer stopped paying for it, right? Or a payer wouldn't recognize the value of it, or, you know.
Yeah.
And I think that gets back to like my comment earlier that insurance companies have become much less price sensitive. So investing in something that's going to keep people healthy isn't necessarily in their interest. So.
I think what we're not hitting on though is, and you know this critique well. So DPCs are great for those who can and know about this as a program and an option. What about your large Medicaid populations? What about your indigent populations? What about those maybe that have all the SDOH risks, social determinants of health risks, and adverse childhood experience risks, and maybe monetary consequences and lack of education? How do they get access to a program like this?
I mean, this is why the only reason we have started working more with businesses is because a CEO can change healthcare for their employees with one signature, right? I don't spend money in this way, I spend money this way.
Okay.
I would love to take care of the Medicaid population. It doesn't depend on one person though, right? It is a much larger system that's going to need to see a lot more evidence before they're going to change. They're going to say, hey, everybody can have access to a DPC. So my long-term goal is businesses can change quickly. They're the initial ones to prove the model. When you have the model more proven, then you can make a dent in Medicaid.
So I'm hearing you say like at scale, like maybe employers are a leverage point.
Right. That's exactly the way to put it. Employers are the leverage point to prove a new model works. Medicaid and Medicare will pay attention to that once you've proven the new model. I think I told you the story before we started. I don't want to tell Dr. Nick's story, but even if you look at something like FQHC, who should have the incentive to take care of this model well, the experience in Wichita with some physicians in FQHC who wanted to do full spectrum medicine, who wanted to provide these services, they thought they were going to be meaningful. The FQHC said, well, we get paid X amount of dollars for a well child. You're more valuable to me just being at a school-based clinic and working with some APPs to do as many well childs as possible. The FQHC has to exist. They're making a rational decision to say like, time for dollars, it's better you do this.
Does Kansas have physician to APP ratios?
I have no idea. I mean, they have independent practice in
oh, they do?
Yeah, for NPs. So.
I've heard of some doctors express the feeling of being a license for hire,
right?
So that they can
supervise.
So they can supervise, maybe four APP advanced practitioners to a physician.
So I think the answer to your question is like, I would love to, I mean, we take care of a decent number of Medicaid children because they pay us, an affordable amount of money and they can get in whenever they want to. And we participate in VFC to be able to vaccinate those children at no cost to them.
What percentage of your program do you think is?
So we have about 30% peds. I would say probably a third of those are either uninsured or Medicaid.
Yeah.
Even within direct primary care. And it is because even if you have Medicaid, that doesn't guarantee I can go somewhere.
Yeah.
And if my kid has an asthma exacerbation at 6 p.m., or 7 p.m., I can either go to the ER, or if I'm a DPC member, they call me and say like, okay, which inhalers have you given? Have you done this?
Yeah.
Do they need oral steroids that I can provide you? Then we can see them the next morning to keep them out of the ER. So what correctly done direct primary care should be providing would be hugely valuable to the Medicaid population. It's just hard to convince the whole system to do what I'm doing as a relatively small clinic.
So you've chosen to not create significant margin off the ancillaries. Mm-hmm. And I again, stop me from putting words in your mouth, but because you want you don't want to change the incentives or the relationship you have with the patient.
Correct.
Wouldn't that give you pharmaceuticals are a big space in the medical continuum that maybe has waste or high margin. How does the DPC give you new opportunities to address those issues?
Yeah, it's one of the, we started working with a company, both Antioch and then me and another person, Molly Breitenbach, have started consulting with businesses to change their health plans. And so this company was with a major carrier and we looked at their top drug spends. And one of the persons was on a generic cancer medication filled at the pharmacy. And the monthly spend on this drug was $1,500 a month. Like that's what was taken out of the employer's account
risk pool
to to pay for it. Like that's what the charge was
Actual
against
dollars,
them.
hard dollars coming against the employer.
Yeah. And they were facing 20% increases because they're like, look at your medicine costs, right?
Okay.
Well, I look at this medication. I was like, I can order that medication. Like I know what that medication costs. And it's like $125 a month for the exact same manufacturer, the exact same pill, the exact same everything. Yeah, 125.
125.
Yeah. And so again, if my incentive is like the PBM's incentive that was working with this major health plan, is like,
what's a PBM?
PBM is a pharmacy benefit manager. So they are the entity that's brokering the transaction between a doctor writing a prescription, a patient picking it up at a pharmacy, and telling them how much that medicine's going to be.
Why do we need that middleman to exist?
I don't. So you
what value adding?
You somewhat need a PBM to say like to keep track of things. So how much money is
like
being
an
spent.
accountant?
Yeah. So that's the correct version. You would also want in a correctly incentivized PBM to find you a good price, right? That would just be theoretically if somebody was helping you with a transaction.
Sounds great.
I mean, think about this. Like, I've never bought an individual stock through a stockbroker. Have you ever bought an individual stock? Yeah. But the best analogy I've ever heard is, and I didn't come up with it, but imagine you called and you said, I want 10 shares or 100 shares of Google.
Yeah. And
the stockbroker is like, yes, Google's trading at $95. I'm going to take my $5 commission on the sale. It's transparent. Okay, we bought you 100 shares of Google.
And I took my $5.
Yeah, but that's the transparent part. Hey, I'm only taking $5 to be the broker. But if you found out later that Google is actually trading at $85, and that person kept $15, like that stockbroker would go to jail. Like that's illegal. It's illegal in all, like everywhere.
Okay.
But that's exactly what PBMs are doing. I'm telling you the price is $1,500. I'm paying $125, and I'm pocketing I'm pocketing the difference. Like that is what PBM's current incentive is when you turn an ancillary service into a profit margin. I just want to stay away from anything that looks like that, if that makes sense. Why do we need PBMs?
Yeah.
You need the accounting of like, okay, they bought these drugs.
So how are they doing this?
How or why or both? I mean,
I think why.
The how is like, so let's go back to the ACA stuff. If I'm a major carrier and I have fully insured plans, meaning they're not self-funded, they're like, hey, I'm 100 people and we're just paying our premium and we go consume healthcare according to the plan. The ACA capped how much money they can make on a plan like that. So I give the Geico example. This is my trick question I ask to anybody when we delve into these realms. Imagine, and stop me if I'm talking too much, but imagine Geico's accountant or actuaries come to Geico in Kansas and say, hey, we think you're going to have $850 million worth of claims. Okay. So Geico, you should take in $1 billion in premiums. You can pay all the claims and have a 15% margin, right? Makes sense. That's how people think of insurance working, right? I have to have some margin to keep my business open. I'm only in this to make some money. I have 15% margin. If you and I started a business that made every driver in Kansas safer, and there was only $750 million in claims, in that year, would Geico make more or less money?
More money.
More money, right?
Yeah, obviously.
Cost went down, still took in the same premium. Over time, if we made all the drivers cheaper, what would happen to the premiums that Geico would charge? Well, they would get lower, right? Because like other insurance providers in Kansas would be saying like, well, I can undercut them because these drivers are safer. So the total cost of insuring ourselves would go down. ACA comes in and I think with good intention said, well, we don't want insurance companies to make too much money. We're going to cap how much they can keep. They can only keep 15%.
Okay.
Right? So imagine...
And I think that's called the medical loss ratio.
Medical loss ratio. Yeah, exactly. So 85% can keep 15% as profit overhead, things like that. So let's use the same scenario and find the incentives though. So I have a fully insured book of business in Kansas. My insurance company's actuaries say, hey, we think there's going to be $850 million worth of claims. Mm-hmm. Taking $1 billion, you can keep your $1,500. Well, so I naively thought like, well, I'm going to start a primary care clinic. I'm going to take great care of people.
Like Boy Scout.
Yeah,
like,
they're going to consume less healthcare. They're going to consume less healthcare. Yeah. The Blue Cross United are going to love what I'm doing because their costs are going to go down. Well, if I actually made their costs $750 million that year, what happens to their profits?
What you just described is it might go down.
It goes down because they have to return that money because they can only keep 15%. So in order for, on a fully insured book of business, prices to go, or revenue to increase, the total cost spent has to go up. So the fact that we see medical inflation is not a mystery. It's built into the way the system works.
Yeah. So,
and even on the Medicaid side, so some people, it might not work in Medicaid, but if we made Medicaid people look healthier on paper, what would be the reimbursement from the government for that person? They would go to a lower risk tier and you'd get paid less for them, right? So an MCO adjudicating Medicaid wants people to look as sick as possible on paper.
Yeah.
If they all looked healthy, their revenues would be cut.
The Affordable Care Act just turned 15 years old. If you were rewriting it, how would you rewrite it?
Yeah, I mean, I think that is too big a question for me to have an intelligent answer on. I think
I'll take an unintelligent answer.
Well, no, I think there's a couple conflations that happen. So one, you're conflating that health insurance is access to care. And I think we have covered that that's not the case. Just because I have a card in my pocket doesn't mean I can access care. So
you're delineating between insurance is not the same as access to healthcare.
Right. Yeah. And that's why we take care of Medicaid kids. Like they have a Medicaid card. If I send a medicine to their pharmacy, it's free for them, but they, it's a 2-month wait to get in to do a well child check or to do some of these things, even with Medicaid in a lot of places. I think the second thing is the ACA made true insurance illegal. So I just had a physician in the doctor's lounge yesterday, 2 days ago, I think. She's like, I think I should just go buy a policy that says if I spend more than $15,000 a year in healthcare, then it will reimburse me. I was like, that's actual insurance. I mean, that's what people think of. That's home insurance, that's fire insurance, that's car insurance. If I wreck my car, if I sustain a catastrophic loss over $1,000, $2,000, whatever I set my premium, I get paid the rest. That insurance policy is illegal to buy in the United States. No one can sell it because
it's illegal.
It's illegal because you have to, if you're going to sell health insurance, it has to be an ACA compliant plan. There are different things you can do with indemnity, but I can't choose to go buy that policy because it doesn't exist in the market. So I think it has constrained the number of things that are able to be purchased on an individual market as well. Because if somebody said, well, I'm going to charge you $99 a month for the $10,000, $15,000 policy, I think you might see some people picking that and getting off their employer insurance and picking that instead. Those are the things that I see as it's changed incentive of insurance companies. It's changed what's able to be purchased in the marketplace. And I tend to assume good intent in that just the secondary consequences weren't anticipated at the time it was written.
Yeah. So, I'm a healthcare executive. You're a physician. Some things you're saying I'm not even fully understanding, but how do we communicate this conversation to someone who's down the street here in Wichita?
Yeah.
And, I talked to someone just the other day. I asked them if they knew who you were. And they said, yeah, they got really excited about a presentation you had given recently. And then I asked them, I was like, have you signed up for Dr. Alleman's clinic services yet? And the answer was no.
Yeah.
Like, how do we go about bridging that gap?
Yeah. But to me, again, that's the thing. Like, we have a system in the United States, which we are working with, but I wish didn't exist, is that your healthcare. So Marty McCary in his book, The Price We Pay, uses the concept of proxy buyers, right? When I go buy something on an online site, I'm looking at reviews, and these people who just love leaving reviews on things help me purchase, right? They're my proxy buyer.
Sure.
So they compare everything and they like these things like, well, now I just know what widget to buy.
Yeah.
Unfortunately, in the United States, the CFO and the HR are proxy buying healthcares for all of their employees. And almost none of the companies have anything to do with healthcare. We take care of a transportation company that they're just trusting their insurance broker to hand them a product, right? And then they purchase it. Well, as soon as they sign that contract, that dictates how healthcare is going to be purchased by all their employees. So the reason the person you're talking to isn't at my clinic is because he has no incentive to. A huge amount of his paycheck and money is going to have this card in his pocket. I don't have anything left to spend on an actual medical home. I'm just going to hope I don't get sick and go to the doctor once a year, right? So that's the reason he hasn't signed up, is because his money's being spent for him in a different way.
Okay. I want to do like 3 to 5 minutes of something
Sure.
kind of rapid with you. So I'm going to ask you like 5 questions.
Great.
Just give me your answers. So
This is like a Rorschach test.
maybe, yeah. Give me a policy you'd change tomorrow to strengthen primary care.
This is the one that's coming to mind. I think that turning healthcare consumers into shoppers would be a good thing. And right now we have this problem of things being in network, out of network. I can deliver a baby, and my professional costs are currently like half the market rate. Well, somebody with a card in their pocket doesn't come to me because my charges aren't going to go to their insurance. It's not going to go to their deductible. But if we said any service that you purchase that's under the current market rate according to your insurance automatically applies to your deductible, you turn everybody into a shopper, if that makes sense. So people would have the incentive to go look for inexpensive labs, to look for inexpensive services, to look for those things. So I don't have to be in network with anybody, but if they say, hey, I got my bill and I got this service and now it applies to my deductible because I was a good shopper, I think it would change the way people consume healthcare, and especially for clinics like mine.
Great. Second one. All right.
That was too long. That was way too long.
It was incredible.
There was nothing rapid about that.
Worst day you've had where you almost gave up on DPC?
I think we've had physicians join us and then chose to leave, and that's probably been the hardest thing. Our clinic's made some mistakes in the past, and realizing that we weren't a fit for other physicians has been hard, but we've grown over time. So that's probably been the hardest thing about doing DPC.
I will ask you this. This is not part of my 5.
Okay.
But I want to ask, what have you learned in terms of what types of physicians are right for DPC?
I think it has to be somebody where clinical care is the focus. So I think
as opposed to what?
Well, I think people come from lots of different scenarios. Like they could be academic, they could be inpatient, like taking care of a population at the outpatient level is what DPC's core value is right now. If I don't want to spend 90% of my day doing that, and I don't want to spend 90% of my day interacting with people on their health, like if I'm not a people person, but I'm good at faking it, then it's going to be a hard job. Whereas like, it would be hard to take a pathologist who wants to be like looking at slides and that's what they like doing and put them in primary care. So I think people just have different tendencies that make them good at primary care or make them like not a fit for primary care.
Okay. 3, give me a single word that describes how you feel about the future of family medicine.
Optimistic.
What makes you optimistic?
I think a lot of people need a job created for them. They're looking for an ideal job. They're not going to go make it. That might be not how they're wired. I think with the advent of community-owned health plans, primary care fits directly into that. It's the most needed thing in a correctly designed health plan.
Yeah. Give me your favorite day as the founder of a DPC.
Knowing when we've impacted people's lives positively.
Give me a story.
We were at a benefit meeting one time, and they're rolling out new benefits. They're explaining, and this is somebody that had used direct primary care for a while, so their employees were familiar with it. We were sitting at the benefit meeting and said, well, we've redesigned our plan to really like build the plan around what direct primary care is doing. So like now, not only is the membership no cost, but the labs are no cost to you, the medications are no cost to you, the procedures they do are no cost to you. An employee raised their hand and like, he's like, and I knew who this was because he's been in our clinic for a while. And he's like, so you're telling me you're giving me a raise by doing healthcare differently? And the HR person's like, I guess so. Yeah, I guess that's what we're telling you. Because like he would have, this person would have to have labs every 2 to 3 months. They would have to have medications every month. And he's like, this cost is now gone. Being able to turn healthcare into something that people view as like, I am scared of consuming because it might bankrupt me and it's taking a lot of my money, into something that is like, our community's better and my workplace is better because we've done healthcare differently. Like those are the meaningful things.
My final question in this section would be, what role does the community play in the health of your patients?
Yeah. Talking about those social determinants of health, shifting our community to have access to like affordable and nutritious foods, having activity be part of the community. I have been on a search for a validated scale of loneliness, because that's like one of the number one things I see. I'm just saying this is brand new for me. I've gotten somebody did a presentation on it. I got their presentation, but I'm just trying to pick the one. So when we diagnose depression or anxiety, we have a PHQ-9 and a GAD-7. So we take a baseline, we start them on medication, or we get them into therapy, and then we follow that. So we have some scale to say, like, I don't have a lab test for depression, but I have some scale to assess it. But what I see a ton is loneliness is happening. And people, like, I will ask people who are not doing well, like, do you have any name that you could go talk to that's a friend, a family member? And it's like, no, I don't have anything. So there's no pill for those things, but the community providing those things are going to make a difference in people's health.
Before I go on, I've just been chewing on what you said about shopping, turning patients into shoppers. But when I go to a grocery store and I want a good watermelon, I kind of pat it and I look for the yellow on the side, and I maybe like take the avocados and see which ones I want. Like, how do we make sure that the shopper knows how to know in healthcare what fruit is ripe and ready to purchase and which is bad and moldy?
Yeah. There's never going to be perfect information like that, in the same way that like cantaloupe's the worst. I'm the worst at picking cantaloupe.
Honeydew might be worse.
It's like 2 hours when when it's the right time to eat a cantaloupe. So
also, do you look for the fruit flies and the gnats when they're around it? It's
ripe,
sweet enough inside. Yeah.
So not going to be perfect information, but I think that's where eventually word of mouth is going to tell you who the people that care, who the people that listen, who the people that spent time with you to like get to the underlying issues, not just give you more medications. Those are the things that are going to help. People are going to be imperfect shoppers. I would say they're, you hear these stories of like, well, I would never go to this. I would never go to a different back back surgeon. He's done my last 3 back surgeries. And it's like, well, why have you had 3 back surgery, right? Right. So yeah, shoppers aren't going to be perfect, but I think the incentive to at least look at price and quality right now is not there. So things will develop to shop if they have that incentives.
Yeah. So we've talked to you. Obviously, your unique voice, Fulbright scholar, MD, PhD, chose to come to not a rural community, but the Midwest, right? You could be anywhere you want. And then you continue to start an alternative trailblazing program with DPCs. I've heard you speak on PBMs in the past as well. So from your lens, what is the single biggest leverage point for transforming healthcare in America right now?
Yeah, I do think it's realizing who pays the bills, and individuals pay all the bills in healthcare, and CEOs and CFOs realizing how much power they have to change the way healthcare is done is probably the biggest leverage point, because they can change fast, right? Okay. Medicare, hard to change, like slower moving. But a CEO and a CFO, I mean, you get 5, 6, 7 businesses in a community and saying, we're doing this differently. That's a big enough market. That's a big enough size to matter. And we're kind of getting that critical mass here in Wichita to say like, hey, we're doing this differently. We want to focus on the things that make our people healthy. We want to do that at a cost point that's going down, not up. The CEO, CFO, HR deciding on healthcare is the biggest leverage point to change healthcare, I think, because they control way more dollars than they realize. So, and it's this bidirectional Stockholm syndrome. So
tell me about that.
So,
is that a Brandon term or is that a real?
Stockholm syndrome is my term. The bidirectional maybe, but like. I will go to the physician lounge and everybody hates insurance companies. And I go to the boardroom and everybody hates insurance companies, but neither of them will leave. Neither of them will like leave that process. Yeah. You said play a different game. I don't think, I think the purchasers a little bit have to be the first mover to play the different game, and then the providers will follow. But right now, no one's willing to play a different game. Well, traditionally, no one has been willing to play a different game. I think we're seeing a movement in that direction that I'm excited about. Wichita is a very cool community to do that in. So,
And you feel like you're building, you say critical mass. What critical mass is being built?
I think when you get to employers, when you get like 1,000 employee lives
Okay.
that are choosing healthcare differently, that's enough to say like this works. You do it with 50, it's like, well, that's cute. But you get to 1,000, you get over 1,000. We're getting to that point where enough people in our area are choosing that.
All right. So, as we come to a close here, so if
and can I say, like, Health Rosetta is an organization that I think has been leading a thought leader on this. So a lot of the things I've learned have come from that organization.
broadly or on PBM specifically,
Broadly on healthcare incentives.
Health Rosetta.
Yeah.
What are they adding to the conversation?
They're a nonprofit that's just saying like, yes, healthcare is this extractive industry. There's a ways to choose something differently. So,
And who are they? Who's behind that?
Dave Chase is the CEO. He's kind of the founder. He's written books kind of on the leverage point that CEOs have. So he's written the CEO's Guide to Fixing American Healthcare. So
What's his background?
he is former Microsoft person, did development in healthcare, and just kind of has been like, wait a second, there's some big problems here.
What's your role with Health Rosetta?
I can't remember if we touched on this. So a couple of years ago, I actually went and took my test to be in a licensed insurance broker in the state of Kansas. And I did that because it's like, yeah, my clinic that I thought was doing good primary care didn't make insurance any cheaper. Remember I told you that delusion I had a few years ago?
Yeah.
So to me, it had to be at the insurance level, the incentive level, that this was different. So
you looked upstream for like maybe where the arbitrage was.
Right.
And you found it at the insurance level.
Yeah. Well, it's at again, CFO is going to a broker and saying, help me find health insurance.
CFO to broker.
Well, CEO, CFO, C-suite and HR going to broker and say, get us health insurance. When we're talking about incentives, most brokers are paid on commission. Well, commission is percentage of premium. So if the premium goes up, the broker's paid more. It's like you've purchased a house ever, right? Mm-hmm. Have you ever used the seller's realtor as your realtor to buy a house? Why not? Why wouldn't you do that?
Incentives, motivations.
Right. Well, that's what everybody does in healthcare. So I'm taking somebody who's mostly paid by the insurance company, a premium. I'm asking them how to buy healthcare. So to me, that was a leverage point. If I want the dollars to be spent differently, you have to get in front of these people with a compelling, different option. My role in healthcare Health Rosetta is they say, hey, here are people that are doing it differently. So you can have a certification if you go through their course to say like, this is somebody doing something different in healthcare.
So I'm seeing a progression. I'm seeing mathematics, science, Budapest, MD, PhD. I'm seeing this alternative path. I like the trailblazing imagery. And here you are as a DPC provider already in the counterculture space of medicine. Now you're moving upstream into the insurance space. Mm-hmm. What's next?
Yeah, I think that's the next thing, is getting a critical mass in an area to purchase healthcare differently. So that's next for us. We've done that with 4 going on 5 kind of groups. It is
groups being employers,
yeah, or school districts, nonprofits, really? All the above. Anybody who's purchasing healthcare, right, for a group of people, empowering them to make different decisions is what's going to kind of transform healthcare at the community level.
Put me in a room. You're meeting with a school district. Mm-hmm. What are you pitching to me? I'm the school district. What are you telling me that I don't know?
Yeah, I think again, they're thinking I'm purchasing health insurance, and we flip the model to say like, one is explaining what insurance is for. So there's 2 qualities something has to be an insurable risk. It has to be unexpected, right? I can't insure myself against going to primary care because it's like, I know I'm going to do that, right? Yeah. That should not be an insurable event. True insurance it's an unexpected event with a very high cost. Do you drive a nice car?
I do.
Did you have insurance to purchase your car?
Not to purchase it.
Yeah. Was it cheap to purchase your car? No. But like, why didn't you have insurance for it? I mean, it's a huge purchase, right? Well, it wasn't unexpected, and you planned to purchase this thing, right? So people think like, well, a knee replacement, like I surely have to have insurance for a knee replacement. It's like, no, like you didn't like fall out of bed and need a knee replacement in 2 hours, right? Like you knew this was coming for a couple of years. You knew this was going to happen, and there's a transparent price for insurance. So I'm sitting to them, I'm saying, we're going to buy you true insurance for the cancers and the transplants and the scary stuff.
Okay.
Right? But we're going to take that. So a typical rate in Kansas is a business is spending about $10,000 per employee per year.
10,000
10,000
in Kansas.
in Kansas. It's higher in other places. But so you have a 100-person group that's $1 million, right? So 100 people, 100 employees are taking your insurance. You're going to pay, like right now, you're paying $1 million in premium. So I'm going to take a sliver of that and I'm going to buy you true insurance. What we're going to do with the rest of that money is we're going to buy you healthcare, right? We're going to buy you primary care in a different way that is now zero access issues and free to all your people. That's currently called direct primary care. You could call it lots of different things. We are
and that's non-fee for service.
Yes, that's a longer.
Let's get technical back on the true insurance though. What's that look like to the CHRO of that company? They're going to have chief human resources officer, the person that
the HR,
the HR person. Yeah. They're going to see higher stop losses probably on their insurance plans, and we can edit this all out later. I'm just trying to understand it actually for myself right now.
A lot of these companies who are mid-sized are going from fully insured.
What's mid-size?
75 to 200.
Okay.
So they're currently fully insured. So they're just getting a premium renewal. They're paying their premium every month.
They're not even self-insured with a TPA.
They're not self-insured. I mean, they have a TPA, but it's through a fully insured plan, right?
Okay.
Whichever buka they pick is their TPA.
So you're shifting them to more of a self-insured plan.
Shifting them to a self-insured model.
With a stop loss on top.
Yes. So functionally, nothing's really changing. They're still on this model. There's just a lag. They don't see any of the cost. They don't see where money's spent. But every year there comes back to be a 15% renewal with no transparency as to why. They're just like, oh, you guys were sick, so here's 15%. We shift them to buying stop loss. If anything catastrophic happens, you're protected against that. And then buying healthcare all the way up to buying the knee replacements, knowing the price of a knee replacement, knowing the price of a hernia surgery, knowing the price of even a transplant. You can know the price of a transplant beforehand. Obviously, that's going to hit the insurance side of how expensive it is, but you're buying them healthcare in a different way. So
give the people that would be listening to this some homework to do. What do you want them to take away and put into action?
Just educate yourself on how the system currently works.
Break that down into a homework assignment.
Yeah, it's look at the incentives. We can create a book list if you want that we can append to this podcast. But it's
that'd be awesome.
Look at the incentives of people selling health insurance.
Has anyone mapped this out already?
The book I referenced earlier, The Price We Pay, is probably so when med students and residents rotate with us, it is much more a practice management rotation. There's some clinical, they see patients with us, but they spend half their day reading. And I give them, Priced Out by Uwe Reinhardt is a good one. The Price We Pay by Marty McCary is a good one. Right. Catastrophic Care is a good one. Seeing how the system is currently operating then gives you the leverage point to say. And then Relocalizing Healthcare by Dave Chase from Health Rosetta is a good one.
Okay.
That's going to give you what incentives are brokers facing? What incentives are CEOs and CFOs and HR facing? Their often incentive is don't rock the boat, right? Because my employees are going to be mad. Just in the last 2 weeks, though, you have seen JP Morgan, individual C-suite people, be named in a lawsuit for spending healthcare dollars inappropriately. Because if I put myself with a PBM that's charging me $1,000 more than it should be a month, you have breached your fiduciary duty, right?
Yeah, and what's ironic here is JP Morgan has the nation's largest healthcare conference annually in San Francisco.
I didn't know that.
Yeah, so JP Morgan is seen as the institutional thought leader of the system.
But as long as we have employer-based health, which that's probably not in this conversation, but as long as CEOs, CFOs, HR are purchasing healthcare for their employees, they have a fiduciary responsibility to spend those dollars well. If you're putting them with a PBM that's charging you $1,000 more for one pill, or 30 pills each month, you're probably going to get sued. So you should educate yourself.
So there is hidden costs and risks are inherently in the system already for these folks. Yeah. So that's how people can educate themselves more on the topics. But what about on Brandon and the work you're doing with Candid and Antioch Med? Where can people go to engage more on that?
Yeah, you can find more about our direct primary care, antiochmed.com, and see the physicians we have in direct primary care. I think Health Rosetta, if you're in Kansas, come talk to us about your business, right? We are focusing locally specifically because we don't want to be a point solution that's trying to be everywhere all at once. We want to build a community health plan that's truly focused on a community. But there are other people who are doing what we're doing. So see the successes that happen with, and again, I use Health Rosetta because that's the one I'm familiar with. I'm sure there are other examples of people building community health plans, but see what those look like and who's near you doing innovative work like this. That's just a good resource just to find those locations. So, and I would say not every organization is perfect. Not every DPC operates like we do. Not every person connected with Health Rosetta does.
Is that a feature or a weakness of DPCs, the variability?
It's just a reality, I guess. Again, I don't begrudge the non-combatants for having their smaller practices. Great. I'm glad it works for them.
If non-combatants is something else here, what are you?
I would like to think I'm trying to be on the right side of the fight. So that's the goal, at least. Hopefully I'm on the right side.
Yeah. Well, I think that my big takeaways today, I'm going to be chewing on that Trailblazer concept quite a bit. And really the imagery around there's leaders that are leading down a road or a trail, but there's also those that created the trail and there's risks inherently in that. And I really appreciate the imagery. I really appreciate that imagery. So thanks for showing us what's possible and helping us think differently.
This is great.
Yeah. Thank you.
Thanks.